The Recovery Kernel. Substance-Specific Navigation Series. How to recover from inhalants. Volatile solvents, nitrous oxide, poppers, alkyl nitrites. Using the Recovery Kernel Framework. Glue, spray paint, gasoline, butane, toluene, N-hexane/whippets, laughing gas, nong/amyl nitrite rush, jungle juice, locker room. Warning: harm reduction resource, not medical advice. Crisis, call 911 or text 988. Sudden sniffing death, volatile solvents, can occur on the first use. There is no safe amount. Poppers plus Viagra/Cialis/Levitra equals potentially fatal hypotension. Do not combine. Nitrous oxide destroys vitamin B12. MTHFR variant carriers face dramatically elevated neurological risk. How to use this guide: 3 substances, 1 framework. This guide covers 3 categories of inhaled substances that share an administration route but almost nothing else. Their mechanisms, dangers, populations, and recovery architectures are distinct. Using the wrong framework for the wrong substance produces incomplete understanding and incomplete recovery. Find your category and go directly to that part. The closing, Section 7 onwards, addresses all 3 together for integrated recovery context. Part A, Volatile Solvents. Glue, spray paint, gasoline, butane, toluene, N-hexane, aerosols, correction fluid. The most globally prevalent and most clinically neglected inhalant category. Part A, a note before you begin. Volatile solvent inhalation is the most globally prevalent inhalant misuse category and the least discussed in addiction medicine. It is concentrated among adolescents, street children, and impoverished communities in both high-income and low-income countries, populations that the clinical infrastructure of addiction medicine rarely reaches. Brazil, Mexico, Sub-Saharan Africa, South Asia, Aboriginal communities in Australia and Canada. Solvents are the substance of the economically excluded, available in any hardware store, invisible to drug testing, and producing some of the most severe neurological damage in the addiction landscape. The compendium's principle applies here with particular force: the substance was a signal. In the solvent context, the signal frequently points to deprivation, of safety, of nutrition, of warmth, of belonging, of any future that feels real. The CNS depressant effects of toluene and other solvents, the warmth, the floating, the brief dissolution of a life that is otherwise unbearable, are pharmacologically coherent responses to intolerable circumstances. There is no MAT for solvent inhalation. There is no pharmacological reversal agent. Recovery requires addressing the substance and the conditions that made the substance necessary, and that second part is often the harder work, because it involves the social, economic, and systemic factors that clinical pharmacology cannot solve alone. Section 0A, Immediate Safety, Sudden Sniffing Death. Warning: sudden sniffing death syndrome, SSDS, is the primary acute kill mechanism for volatile solvents. It can occur on the first use, with no prior cardiac history, in any age group. There is no warning. There is no safe amount. Classical building the centurion, the cardiac sensitization mechanism, why the first hit can be the last. Volatile solvents sensitize the myocardium to catecholamines, adrenaline/epinephrine. When the solvent-sensitized heart is exposed to a surge of catecholamines, from the physical shock of inhalation, from being startled, from any acute sympathetic activation, it may fibrillate. Ventricular fibrillation is cardiac arrest. If SSDS occurs, call 911 immediately. Begin CPR. The ventricular fibrillation requires defibrillation. Standard CPR maintains circulation until defibrillation can occur. Do not attempt to move the person to a car, wait for EMS. If you find someone unconscious after solvent use, recovery position. Call 911. Do not startle or shake them aggressively. Catecholamine surge onto the sensitized heart can trigger arrhythmia during attempts to wake someone who is intoxicated but not in cardiac arrest. 0A.2, Hypoxia, the second mechanism. Volatile solvents displace oxygen in the inhaled air, particularly with bagging methods. Hypoxia, oxygen deficiency, occurs rapidly and can produce loss of consciousness before the person can remove the bag. Alone, this is a significant risk. Never use solvents alone. Hypoxia-induced unconsciousness with a bag over the head is rapidly fatal. Never use near fires, sparks, or open flames. Butane and many other solvents are highly flammable. Fires and explosions have killed people in the act of inhalation. Burns to face and airway from flaming solvent vapor require immediate emergency care. Call 911. 0.3 Ongoing medical emergencies from chronic solvent use. Encephalopathy, confusion, cognitive impairment, loss of coordination that does not resolve between uses, emergency evaluation. Peripheral neuropathy, N-hexane specifically progressive weakness and numbness in hands and feet, neurological evaluation. Renal tubular acidosis, toluene electrolyte disturbances producing profound weakness, emergency evaluation for electrolyte panel. Chemical pneumonitis, aspiration of solvent or solvent-saturated material into lungs, emergency evaluation for breathing difficulty. Section 1A, What volatile solvents did. Classical building the centurion, the CNS depressant that works through three simultaneous mechanisms. Volatile solvents are pharmacologically complex. They are not specific receptor agonists or antagonists but physical-chemical agents that disrupt neuronal function through multiple mechanisms simultaneously. This makes them uniquely toxic at the biological level and uniquely difficult to characterize at the pharmacological level. 1A.2 Substance-specific toxicity profiles. 1A.3 What solvents were providing, the signal. The compendium's substance masking analysis applies. The solvent was a signal. In the global context of solvent inhalation, the signal most commonly points to physical warmth in cold environments. The vasodilation and CNS depression produce warmth. Street children in cold climates inhale solvents to stay warm. This is not metaphorical, it is thermal regulation through pharmacology when other thermoregulation is unavailable. Suppression of hunger. CNS depression reduces the subjective experience of hunger. Children who cannot access food inhale solvents to make starvation more tolerable. Escape from pain, physical injury, abuse, and the pain of deprivation are temporarily suspended by solvent-induced CNS depression. The solvent is the only available analgesic. Social belonging. Solvent use frequently occurs in peer groups. The substance is the social currency and the shared ritual. Suppression of trauma symptoms. The hypervigilance, flashbacks, and anxiety of unaddressed trauma respond to CNS depression in the short term. Solvent use as PTSD self-medication is clinically documented. Section 2A, Genomic Blueprint for Solvent Recovery. The genomic profile for volatile solvent recovery is less specific than for other substances in this series. Because the mechanism is physical-chemical rather than receptor-specific, the genetic variability of response is less dramatic. The most important genomic factors are those relevant to the CNS depressant dimension, GABA2, the same gene as for alcohol, and the methylation support needed for neurological repair. Section 3A, Biological Reconstruction, Solvent Recovery. Classical building the centurion, the brain can repair itself, with the right conditions and enough time. Neuroimaging studies show that some of the white matter damage from toluene and other solvents is reversible with sustained abstinence, particularly the diffuse leukoencephalopathy, which shows measurable recovery at 1 to 2 years in adults. The peripheral neuropathy of N-hexane also shows partial recovery. The cognitive impairment of chronic solvent use shows significant improvement at 6 to 12 months of abstinence. The brain's capacity for repair is real, but it requires the conditions and the time. For N-hexane peripheral neuropathy specifically, physical therapy for the peripheral nerves is as important as supplementation. Occupational therapist or physiotherapist guidance for the hand and foot weakness and sensory loss that N-hexane neuropathy produces. Some recovery occurs over 1 to 2 years with abstinence. How much depends on severity and duration of exposure. Section 4A, The Recovery Framework for Solvent Use. Classical building the centurion, the substance was the signal. The signal points to conditions, not just chemistry. Solvent recovery that addresses only the pharmacological dimension, the GABA, NMDA, and membrane disruption, without addressing the conditions that made solvent inhalation necessary will fail. The recovery kernel framework requires naming what the substance was providing and building sustainable alternatives. For solvent users in impoverished contexts, this requires structural support, housing, nutrition, safety, education, economic opportunity. These are not peripheral to recovery. They are recovery. No supplement protocol repairs the brain of a child who returns to homelessness and cold after each clinical visit. Housing stability, the most important single determinant of solvent recovery outcome in the literature. Unstable housing is associated with continuing use regardless of treatment intensity. Nutritional rehabilitation, the malnutrition that often accompanies solvent use, particularly in adolescent and street-involved populations, must be addressed as a concurrent medical issue. Protein, thiamine, B1, folate, zinc, and iron are the priority nutrients. Trauma treatment, the majority of people with chronic solvent use disorder have significant trauma histories. Trauma-informed care, not standard addiction counseling, is the appropriate therapeutic framework. Educational and vocational pathways, for adolescent and young adult solvent users, the alternative to the substance context requires concrete pathways to a different future. Vocational training, educational support, and mentorship are recovery tools. Community and belonging, solvent use is often communal, the group using together is a community. Recovery requires replacing that community with one that does not use. This requires deliberate construction, not just cessation. Part B, nitrous oxide. Whippets, laughing gas, nongs, N2O balloons, hippie crack. The compendium names it directly, adverse reactions to nitrous oxide MTHFR likely +2. Part B, a note before you begin. Nitrous oxide is the most publicly normalized of the three substances in this guide. It is used by dentists, in operating rooms, as a food propellant, whipped cream canisters, and recreationally at festivals, parties, and in private settings worldwide. Its UK ban in 2023 reflected growing clinical concern about neurological consequences that had not been adequately communicated to users. The compendium places nitrous oxide in the MTHFR phenotype scoring table precisely, adverse reactions to nitrous oxide, dental, MTHFR likely +2. This is not a footnote. It is the most clinically important fact about nitrous oxide in the context of pharmacogenomics. People with MTHFR variants are dramatically more vulnerable to nitrous oxide's neurological toxicity than people without, because the mechanism of nitrous oxide's toxicity is the irreversible destruction of vitamin B12, and MTHFR variants already impair the methylation cycle that B12 supports. Understanding this mechanism completely changes the risk calculus. What is a brief, benign dissociative experience for one person is a potential neurological injury event for another, and the difference is invisible without genetic testing. Section 0b, Immediate Safety, Nitrous Oxide. Warning: nitrous oxide used from tanks or balloons in enclosed spaces with inadequate ventilation can cause asphyxiation. Deaths from oxygen displacement have occurred. Always use in well-ventilated spaces and never directly from a pressurized tank. Section 1b, What nitrous oxide did. Classical building the centurion, the anesthetic gas that destroys B12, irreversibly, every time. Nitrous oxide has two pharmacological identities. The first is the one that makes it recreationally compelling, NMDA receptor antagonism, like ketamine, producing 30 to 60 seconds of profound dissociation, giddiness, auditory distortion, and the sensation of leaving ordinary consciousness. The second is the one that makes it neurologically dangerous, irreversible oxidation of vitamin B12. 1b.1, the NMDA mechanism. Nitrous oxide blocks NMDA glutamate receptors, the same mechanism as ketamine and dextrorphan, from DXM. The brief dissociation, the giddiness, the auditory effects, and the out-of-body quality of nitrous all reflect NMDA antagonism and its downstream effects on the default mode network. The short duration, 60 to 90 seconds, is because nitrous clears the bloodstream rapidly through the lungs. The same route of entry is the route of exit. Repeated balloon use in rapid succession, a common festival pattern, maintains continuous NMDA blockade and dopamine release. The compulsive quality of nitrous use, the next balloon immediately after the last, reflects the very short effect window combined with dopamine-mediated wanting. The NMDA rebound between balloons, a mini-glutamate surge as the nitrous clears, may also drive the rapid readministration. 1B.2, the B12 destruction mechanism, the clinical crisis. Classical building the centurion, the compendium names it, adverse reactions to nitrous oxide equals MTHFR likely +2. This is the unique and critical pharmacology of nitrous oxide that distinguishes it from every other NMDA antagonist in clinical use. 1B.3, subacute combined degeneration, SACD the neurological consequence. Warning: subacute combined degeneration of the spinal cord is a serious, partially reversible neurological condition from nitrous oxide-induced B12 destruction. It is increasingly common in recreational nitrous users and is often misdiagnosed. If you have tingling, numbness, or weakness after nitrous use, get B12 testing and neurological evaluation now. SACD occurs when B12 deficiency causes demyelination, loss of the insulating sheath, of the dorsal and lateral columns of the spinal cord, the pathways that carry sensory and motor information between the brain and body. The condition is called combined because both dorsal, sensory, and lateral, motor, columns are affected. Risk factors for SACD: frequent nitrous use, multiple balloons per session, repeated sessions, pre-existing B12 deficiency, vegan/vegetarian diet, older age, chronic metformin use, pernicious anemia, MTHFR C677T or A1298C variants, impaired methylation amplifying B12, dependent pathway impairment. Concurrent folic acid supplementation without B12 can precipitate SACD by stimulating cell division in the presence of B12 deficiency. Section 2b, your genomic blueprint for nitrous recovery. MTHFR is the defining gene for nitrous oxide risk, named directly in the compendium. CYP2D6 plays no role. The genomic risk is entirely through the methylation pathway. Section 3b, biological reconstruction, nitrous recovery. Classical building the centurion, the methylation cycle must be fully rebuilt, B12 first, then the full methylation stack. Warning: if neurological symptoms are present, tingling, weakness, ataxia, start methylcobalamin immediately and seek neurological evaluation. Every week of delay at the symptom stage is additional myelin damage. 3B.2, when to see a doctor, the neurological assessment. Any tingling, numbness, or weakness after nitrous use, B12 serum level plus methylmalonic acid, MMA, plus homocysteine testing immediately. Neurological examination if symptoms are present. B12 serum level greater than 500 pmol/L is adequate. 300 to 500 is borderline. Less than 300 is deficient. Note: nitrous can produce functional B12 deficiency even with normal serum B12, MMA and homocysteine are more sensitive markers. SACD suspected, MRI of the spine, looking for signal changes in dorsal and lateral columns, plus neurologist referral. Do not wait. Intramuscular B12, hydroxycobalamin or methylcobalamin physician-administered injections provide faster and higher plasma B12 than oral supplementation. Standard treatment for established SACD. Do not delay this to see if oral supplementation is sufficient if neurological symptoms are present. Section 4b, natural porting, what nitrous provided. Classical building the centurion, the 60-second door to non-ordinary states, building the door that doesn't cost myelin. Nitrous oxide's NMDA mechanism produces a brief DMN suppression similar to ketamine, the ego dissolves, the ordinary narrative of self temporarily suspends, there is sometimes laughter, sometimes profound peace, sometimes the sensation of vast significance. The Ketamine Guide and LSD Guide's natural porting frameworks both apply here: meditation for DMN suppression, NSDR for the hypnagogic adjacency, contemplative practice for the non-ordinary state access. The specific quality of nitrous, the brief, intense, easily accessed door, makes it particularly compelling at festivals and social events where sustained meditation is not available. Building a sustainable alternative does not require the same duration or setting. Breath work, holotropic breathing, pranayama, can produce brief DMN suppression adjacent states that are pharmacologically coherent alternatives to the nitrous mechanism, through CO2/O2 balance shifts affecting NMDA receptor activity rather than direct antagonism. For 7-8 breathwork, sustained extended practice produces mild NMDA adjacent effects through CO2 retention effects on NMDA receptor function. Not as dramatic as nitrous but genuine and cumulative. Holotropic breathwork, guided, can produce states that experienced users describe as qualitatively similar to mild-moderate nitrous at extended sessions. Yoga Nidra/NSDR, the hypnagogic state between waking and sleep, involves endogenous DMN suppression closely related to the nitrous experience. Daily practice builds reliable access. Deep meditation, jhana/absorption states, the deepest available non-pharmacological alternative to the DMN suppression that nitrous produces. Requires months of daily practice to access reliably. Part C, poppers/alkyl nitrites. Amyl nitrite, butyl nitrite, isobutyl nitrite, rush, jungle juice, locker room, TNT, hardware store. Mechanism: nitric oxide release, smooth muscle relaxation. Not the same as solvents or nitrous. Part C, a note before you begin. Poppers occupy a unique position in the inhalant category and in this guide series. They are chemically, mechanistically, and culturally distinct from volatile solvents and nitrous oxide. They have no significant CNS receptor mechanism, they do not produce intoxication, sedation, dissociation, or euphoria in the conventional sense. Their effect is peripheral, relaxation of smooth muscle in blood vessel walls and the internal anal sphincter, producing a brief intense head rush and the specific sexual utility that has made them a fixture of gay male sexual culture for decades. The Chemsex guide in this series references poppers within the MSM community context. This guide addresses them as a standalone substance category, including their specific acute dangers, which are entirely different from solvents and nitrous, their sexual context, their compulsive use patterns, and the recovery architecture that serves people who want to stop. The conventional addiction framework does not apply well to poppers. They do not produce the dopaminergic reward circuit activation that drives conventional addiction, have no withdrawal syndrome, and produce no physical dependence. What they produce is compulsive use in specific sexual contexts and specific physiological risks that require clear clinical communication. Section 0C, Immediate Safety, Poppers. Warning: poppers plus erectile dysfunction medications, sildenafil/Viagra, tadalafil/Cialis, vardenafil/Levitra, avanafil/Stendra, equals potentially fatal hypotension. This combination has killed people. Never combine these. Classical building the centurion, the drug interaction that is consistently underestimated, because both are not really drugs. Poppers dilate blood vessels by releasing nitric oxide. ED medications dilate blood vessels by inhibiting the enzyme, phosphodiesterase 5, that normally removes cyclic GMP, the signal nitric oxide generates. Both effects are additive. Combined, the vasodilation is massive and uncontrolled. Blood pressure can drop to levels that cause syncope, myocardial infarction, and death. 0C.2, methemoglobinemia, the blood oxygen crisis. Warning: methemoglobinemia is a potentially life-threatening complication of popper use that requires emergency treatment. It is most common with ingestion, swallowing poppers, G6PD deficiency, or very heavy inhalation. Poppers oxidize hemoglobin, converting iron from Fe2+, the form that binds oxygen, to Fe3+, the form that cannot. Methemoglobin, Fe3+ hemoglobin, cannot carry oxygen. Methemoglobinemia is the clinical condition of having too much methemoglobin in the blood to adequately oxygenate tissues. Signs: cyanosis, gray-blue discoloration of lips, tongue, skin, headache, dizziness, shortness of breath, confusion, chest pain, occurring during or after popper use. G6PD deficiency dramatically increases methemoglobinemia risk. G6PD is required for regenerating Fe2+ hemoglobin. Without it, methemoglobin accumulates rapidly. G6PD deficiency is present in approximately 10% of African American males and significant proportions of Mediterranean, Middle Eastern, and South Asian populations. If methemoglobinemia is suspected, call 911. Treatment is intravenous methylene blue, which reduces Fe3+ back to Fe2+. This is a hospital emergency. The highest risk scenario is accidental ingestion, swallowing poppers, rather than inhalation. The dose is much higher and the absorption is systemic. 0C.3 Poppers-associated maculopathy. Warning: certain popper formulations, especially those containing isobutyl nitrite or isopropyl nitrite, cause retinal toxicity, maculopathy, that can permanently impair central vision. This may develop weeks after exposure with no acute warning. Poppers-associated maculopathy is retinal toxicity affecting the macula, the central vision area of the retina. The exact mechanism is not fully established but appears to involve the alkyl nitrite compounds directly damaging photoreceptors and the retinal pigment epithelium. Compounds with documented high maculopathy risk: isobutyl nitrite and isopropyl nitrite. Cyclohexyl nitrite, banned in the EU specifically for this reason. Amyl nitrite has a lower documented maculopathy rate but is not risk-free. Symptoms: blurred central vision, visual distortion, a gray or dark spot in the center of vision. Can develop days to weeks after exposure, not necessarily immediately during use. If visual symptoms develop after popper use, ophthalmology evaluation urgently, specifically asking for macular OCT, optical coherence tomography. Some maculopathy cases are reversible if caught early, others produce permanent central vision loss. Risk reduction: avoiding isobutyl and isopropyl nitrite products, reducing frequency of use, stopping if any visual changes occur. Section 1C, What Poppers Did. Classical building the Centurion, pure nitric oxide pharmacology, not a CNS drug. Poppers, alkyl nitrites, amyl nitrite, butyl nitrite, isobutyl nitrite, work through a mechanism that is entirely different from every other substance in this guide series. They do not activate opioid receptors, dopamine receptors, GABA receptors, serotonin receptors, or NMDA receptors. They do not produce intoxication in the conventional CNS sense. Their mechanism is peripheral. Alkyl nitrites are converted to nitric oxide, NO, in vascular smooth muscle cells. Nitric oxide activates guanylate cyclase, producing cyclic GMP, which causes smooth muscle relaxation and vasodilation. The effects are: vasodilation, blood vessels dilate throughout the body, arteries and veins simultaneously. The blood pressure drops rapidly. Blood rushes to the periphery. The characteristic head rush is the result of sudden cerebral vasodilation followed by mild hypotension. Internal anal sphincter relaxation: the internal anal sphincter is smooth muscle, it relaxes with the NO mechanism. This is the primary sexual utility of poppers in receptive anal intercourse and is the specific reason for their widespread use in MSM communities and increasingly across sexualities. Genital smooth muscle relaxation: vasodilation in genital tissue enhances engorgement and sensation. Some users report enhanced orgasm intensity. Duration: the effect is brief, 1 to 3 minutes, because the NO is rapidly metabolized. This short duration drives repeated use during a sexual encounter. 1C.2, the sexual context and why addiction looks different here. Poppers do not produce conventional addiction through dopaminergic reward circuit activation. The mechanism that drives compulsive use is different, it is contextual conditioning. The popper use is tightly paired with a specific sexual context, receptive anal intercourse. The sexual context, arousal, partner, specific behaviors, becomes a powerful cue that fires the desire for poppers through Pavlovian conditioning, even when the person has decided to stop. The sexual utility is real and functional. The sphincter relaxation and sensation enhancement serve a genuine purpose that the person experiences losing when they stop. This is different from most substance withdrawal, where the purpose the drug served was itself a pharmacological artifact. Community normalization. Poppers are highly normalized in gay male sexual culture. Stopping may feel like cultural departure, losing a shared ritual, being out of step with the community. This social dimension of the addiction requires acknowledgement. Compulsive frequency escalation. Some people progress from occasional use to use in every sexual encounter, then to use as a prerequisite for sexual engagement, then to use outside of sexual contexts. The conditioning can generalize. 1C.3, the Compendium Connection, Chemsex Guide and MSM Context. The Chemsex Guide in this series addresses poppers within the broader context of MSM chemical intimacy practices. The sexual identity dimension of poppers use is real. For many people, stopping poppers requires renegotiating their sexual practices and potentially their identity within a community where this practice is normative. The recovery framework must hold this without pathologizing either the sexuality or the community. The same principles as the Chemsex Guide apply. The sexual practices themselves are not the problem. The compulsive loss of agency, using every time regardless of choice, inability to have sex without them, escalating use, is the target of recovery, not the sexuality or the specific acts. Section 2C, Genomic Blueprint for Poppers. Poppers have minimal pharmacogenomic profile compared to other substances in this series, because they do not act on neuroreceptor systems with known genetic variability. The most relevant genetic factors are for risk of the specific complications. G6PD deficiency, X-linked dramatically increases methemoglobinemia risk. Testing recommended for anyone from a population with high G6PD prevalence, African, Mediterranean, Middle Eastern, South Asian, who uses poppers. Approximately 10 to 15% of African American males have G6PD deficiency. Nitric oxide synthase gene variants, NOS3 variants that affect baseline nitric oxide production or signaling may affect the intensity of popper effects. The vasodilation magnitude varies between individuals partly for genetic reasons. PDE5 genetic variants, phosphodiesterase 5 activity varies genetically. Lower baseline PDE5 activity means the cGMP signal from poppers lasts longer, producing more potent and longer-lasting effects from the same amount. This may also increase the interaction risk with ED medications. Section 3C, the Recovery Framework for Poppers. Classical building the centurion, not chemical dependency, contextual conditioning requiring sexual practice renegotiation. There is no withdrawal syndrome from stopping poppers. There is no pharmacological dependence. There is no medical detox. What stopping poppers involves is cognitive behavioral work around the conditioned sexual context, the sexual arousal and specific behaviors that have been paired with poppers through hundreds of repetitions will trigger the desire for poppers. The craving is real, it is contextual and conditioned rather than pharmacologically driven. CBT, specifically for the sexual conditioning, is the primary therapeutic approach. Sexual practice exploration without poppers, deliberately engaging in the sexual practices previously dependent on poppers without them. This is discomfort tolerance work. The practices may feel different, potentially less comfortable initially, as the conditioned expectation adjusts. This is the extinction process. Negotiating the social and community dimension. For people in communities where poppers are normative, stopping may require both internal identity work and explicit communication with partners. The compendium's Chemsex sexual rehabilitation framework applies. Medical monitoring for specific complications, retinal evaluation, OCT, if any visual symptoms have occurred or if isobutyl nitrite formulations were used heavily. G6PD testing if not already known. Blood pressure monitoring in the first weeks of cessation, BP may be slightly elevated without the vasodilation effect. 3C.2 Harm reduction for active use. Never combine with ED medications, sildenafil, tadalafil, vardenafil, avanafil, riociguat. This is the primary harm reduction message. The vasodilatory synergy is potentially fatal. Know the compound in the product. Prefer amyl nitrite over isobutyl or isopropyl nitrite for lower maculopathy risk. Check product formulation when possible. Never ingest. Alkyl nitrites are for inhalation only. Ingestion produces dramatically higher methemoglobin formation and systemic toxicity. G6PD testing. Know your status. If G6PD deficient, the methemoglobinemia risk from poppers is high enough to warrant cessation. Monitor vision. Any changes in central vision after popper use warrant immediate ophthalmology evaluation. Reduce frequency. The maculopathy and methemoglobinemia risks are dose-related. Reducing frequency reduces cumulative exposure risk. Section 7. The Integrated View, 3 Inhalants, 1 Framework. Classical building the centurion. What unites these three substances is what we have not given them, adequate clinical attention. Volatile solvents, nitrous oxide, and poppers are administered by the same route, inhalation, but their pharmacology, their populations, their risks, and their recovery architectures have almost nothing else in common. What they share is clinical invisibility. Volatile solvents are the substance of the globally excluded, street children, impoverished adolescents, communities without economic futures. Addiction medicine has rarely gone where they are, and when it has often brought frameworks built for populations that look nothing like them. Nitrous oxide is the substance that is simultaneously a medical tool and a casual festival ritual and, for people with MTHFR variants, a B12 destruction event whose neurological consequences develop weeks after a night of balloons and are often attributed to everything except the correct cause. The compendium names the MTHFR connection. Most clinicians do not. Poppers are the substance that gay male sexual culture normalized so thoroughly that the legitimate harms, the methemoglobinemia, the maculopathy, the fatal interaction with ED medications, the contextual compulsion that develops for some users, have been underdiscussed precisely because of that normalization. Harm can be reduced without pathologizing the sexuality or the community. The recovery kernels framework applies across all three. What was this substance providing? For the solvent user, warmth and the suppression of an unbearable life. For the nitrous user, a 60-second door to non-ordinary states. For the popper user, functional sexual enhancement and access to a communal ritual. Each signal points to what recovery must provide. Structural support and safety for the solvent user. Non-chemical access to non-ordinary states for the nitrous user. Sexual practice renegotiation and community navigation for the popper user. No supplement stack addresses the deprivation that drove solvent use. No meditation practice reverses SACD once it is established. No CBT protocol eliminates a G6PD deficiency's methemoglobinemia risk. Recovery requires the correct level of intervention for the specific problem the substance was solving and the specific damage it caused. The compendium was built for the person who ran out of time before anyone asked the right questions. In the inhalant category, that person is often the most vulnerable and the least served. This guide asks the right questions. Solvent harm reduction, sniffingglue.org nitrous B12, pernicious-anemia-society.org G6PD testing, discuss with GP. Refer to the Recovery Kernel Complete Centurion Compendium for all referenced protocols. Crisis, call or text 988 Emergency, 911 SAMHSA, 1-800-662-43517 line, 1-800-852-8336. Warning: harm reduction resource, not medical advice. How to recover from inhalants using the Recovery Kernel Substance-Specific Navigation Series.